Hello, everyone. We're going to be talking today about mechanical dilatation in vasospasm cases in aneurysmal subarachnoid hemorrhage. I'm going to show you a little case and discuss some tips and tricks to use with the NeVa device. So this is a 57-year-old with history of alcohol and tobacco use. Patient has type 2 diabetes, hypertension, hyperlipidemia. On April 5th, patient developed a headache with a syncopal episode in a fall. They didn't actually show up for evaluation until April 8th and presented with altered mental status. This is what the initial CT head looked like. And based on this, most of you should know this is what aCOM aneurysms can look like. And the patient presented with a Hunt Hess 1 Fisher grade 3 aneurysm subarachnoid hemorrhage. CTA did show the aCOM aneurysm, and the patient was taken a cath lab for treatment. Now, patient developed vasospasm, so we had discussed with the team some options, and typically we will do infusion of verapamil for 1 or 2 days first, and then if it doesn't improve, we'll use the NeVa device. And we like the NeVa device because you actually get stentoplasty without the risk of rupture that you would get with balloon, like a gateway, or definitely we don't use compliant balloons. You want to use a non-compliant balloon that's sized appropriately, but to significantly decrease the risk of rupture, we use something like this. So NeVa is the only FDA-approved device for post-aneurysmal subarachnoid hemorrhage vasospasm treatment. And on post-bleed day 6, you could see here severe vasospasm, despite the day before getting IA verapamil, intraarterial verapamil. Patient got 5 milligrams, I believe, in the right A1, 10 in the left. And as you can see here in the red circle, both A2s are just very tight here on the frontal, and then on the lateral, in between the red circle, you can see how tight they are. So we treated on that day the left side with NeVa, and the right side, we just treated it with intraarterial verapamil. And then immediately afterwards, they both look decent. But now 24 hours later, post-bleed day 7, you could see here that the left side treated with NeVa, the A2 is significantly larger than the right side on the frontal as well as the lateral. On the frontal, you see it within the circle, and on the lateral image, you can see the arrow pointing to a significantly enlarged A2 segment on the left compared to the one below it, which is the right A2. And both sides were treated again with verapamil, and then this time we decided to treat the right as well. So now post-bleed day 2, you can see both A2s now open with significant improvement in vessel caliber, as well as the patient's symptoms. And the patients were treated also with intraarterial vasodilators for the distal branches that were spastic. Post-bleed day 9, you see vasospasm resolution. Basically, no significant vasospasm at all of the anterior cerebral artery A2, A3 segments. And then we also treated the residual aCOM aneurysm with an additional coil. Here's a zoomed in picture, so you can really truly appreciate the difference here. Look how dilated this is post-NeVa, and then look at the other side. And both of them were treated with verapamil. After the NeVa was deployed, we infused 10 milligrams over 10 minutes through the right A1, and you could see it had barely any effect on the right A2. And then next day, we treat the right A2 with NeVa, and then, of course, post-bleed day 9, resolution on both sides. And just an example on the lateral views as well for you to appreciate. Zoomed in, see how tight those A2s are? The 2 arrows here on the left, then basically post-bleed day 8. So only 2 days later, you see both of them are treated. But on day 7, because we only treated one side, IA verapamil just doesn't work, right? You need to plasty these cases. So some of the discussion we wanted around prep and deliver and deploying, we love using a 27 microcatheter with the Aristotle 24 wire. We'll typically take, some people use Trevo Pro 18. Again, I use VIA or Marksman 27. And you deploy the device. It's pretty straightforward. And I wait about 2 to 3 minutes after deploying the device, and then infuse my verapamil through the 27 microcatheter. If you use a 21 microcatheter, you cannot infuse the verapamil. And then we pin and resheath. Sometimes you need to tug on it a little bit. That's one of the reasons why I like VIA or Marksman more. I feel it's much easier to recapture with the 27 microcatheters. And then again, slow and deliberate resheathing into the microcatheter. Do not drag within the vessel. You will possibly dissect or cause worsening vasospasm. If there's slight resistance during resheathing, pause, unload the system, move the microcatheter forward, and then resheath. So one of the reasons why I highly recommend NeVa for vasospasm, you always want to do it before infusion of verapamil in that day, because you need the stentoplasty to actually break those muscular fibers in the blood vessel. When you use verapamil, you've relaxed them, so you don't get the same effect. So you got to select the vessel, deploy the NeVa 2 to 3 minutes, then infuse your verapamil over 5 or 10 minutes, then resheath. And as you can see here, significant improvement basically in 2 days after treating the 2 different sides, decreased length of stay, decreased ICU length of stay, and no risk of rupture like you get with balloon angioplasty. Thank you very much.